All right, so today we're going to talk about the direct oral anticoagulants, abbreviated as DOACs. The ones we're going to talk about are apixaban, rivaroxaban, edoxaban, and dabigatran. The first three are direct factor 10A inhibitors, and dabigatran is a factor 2A or a direct thrombin inhibitor. What we're going to discuss is contraindication to DOAC use, indications, dosing, pharmacology, and clinical trials that look at DOACs. So before we start, we're going to go over indications where we wouldn't use a DOAC. The first is we should exercise caution if the creatinine clearance is less than 15. In patients who are breastfeeding or pregnant, DOACs haven't been studied. If there's drug interactions, DOACs should be used with caution. Some common interactions would be chemotherapies and anti-epileptic medications. For profound thrombocytopenia, we would avoid anticoagulation in general. For antiphospholipid antibody syndrome, particularly the triple positive, we would avoid DOACs. Technically, we should not be using DOACs in antiphospholipid antibody syndrome. For extremes of weight, especially BMIs greater than 120, or BMIs greater than 40 with weights greater than 120, and for profoundly high clot burden, generally we start with some sort of parenteral anticoagulation and then switch to DOACs over time. All right, so we're going to make a table today going over the indications for the four DOACs we are talking about. The first indication would be non-valvular AFib. And for apixaban, the dose we use is 5 milligrams BID and, of course, PO. The indications where we would use lower dose, or 2.5 milligrams BID, is if 2 out of 3 criteria are met. The first one would be a weight less than 60 kilos, age greater than 80, and a creatinine of greater than 1.5. So obviously that's American units. For edoxaban, non-valvular AFib dosing, we use 60 milligrams once daily if normal creatinine clearance. If abnormal creatinine clearance, so creatinine clearance of less than 50, we can use 30 milligrams daily. For rivaroxaban, we use a dose of 20 milligrams for non-valvular AFib. For lower creatinine clearance, you can also go to 15 milligrams if the creatinine clearance is less than 50. Dabigatran, for creatinine clearance of greater than 30, we use 150 milligrams BID. If the creatinine clearance is less than 30, then we would use 75 milligrams BID. So that's non-valvular AFib. For VTE, dosing is a bit different. So for apixaban, we use 10 milligrams BID for the first week. And then after that, you can use standard dosing, 5 milligrams BID. For and there's no need for bridging with that. For edoxaban, there is need for parenteral anticoagulation, and the first 5 to 10 days of therapy should be overlapped with some sort of parenteral anticoagulation and bridging. For creatinine clearance of greater than 50, we use the dose 60 milligrams once daily. Otherwise, you can use a dose of 30 milligrams once daily, similar to the AFib dose. So that's for edoxaban. For rivaroxaban, dosing is 15 milligrams BID for the first 3 weeks. And then thereafter, you can do 20 milligrams once daily. And then finally, for dabigatran, dosing is you do need to use parenteral anticoagulation for an overlap. There is a need for bridging here. And we use the dose of 150 milligrams BID if the creatinine clearance greater than 30. Otherwise, you should exercise caution. Okay, so let's keep going. So after you've treated your patient for the full course of anticoagulation that you've planned, you might consider keeping them on anticoagulation lifelong because you might evaluate their risk as being high of developing recurrence. So you can actually use DOACs for lifelong VTE prevention as well. So for apixaban, the dose we would use is 2.5 milligrams BID, and you'll notice that that's a lower dose. For edoxaban, secondary prevention is actually not approved. For rivaroxaban, the secondary prevention dose can be 20 milligrams is approved, and there is a trial that we will talk about shortly called the Einstein Choice trial, which has looked at 10 milligrams as well. So you can continue on with 10 milligrams. And then for dabigatran, you can extend prophylaxis with standard VTE dosing. For total hip replacement and total knee replacement, both approved for apixaban, so we use 2.5 milligrams BID. It should say BID. And for the total hip replacement, you actually do 35 days of that. For the total knee replacement, you do 12 days of that. For edoxaban, not approved for total hip and total knee replacement. For rivaroxaban, the doses that we use for total hip replacement are 10 milligrams and total knee replacement, but the duration is also the 35 and 12 days for total hip and total knee. Break that down. And then finally, for dabigatran, we use in total hip replacement, not knee replacement, because it's not approved in knee replacement. You can use 120 milligrams for the first day, and then going forward, you do 220 milligrams daily. So the half-life for the DOACs are all fairly similar. For apixaban, we say 8 to 14 hours, and the range will differ depending on the resource you find. For edoxaban, it's 10 to 14 hours. For rivaroxaban, 5 to 13 hours. And dabigatran is 12 to 17 hours. Importantly, rivaroxaban, you need to take with food. So I'll put that as a specification here. And it's very important that you do not chew or break open dabigatran, as bioavailability will increase by about 75%. So take the tabs whole. The max effect for apixaban is 3 to 4 hours. For edoxaban is 1 to 2 hours, and for rivaroxaban 2 to 4 hours, and then for dabigatran is 1 to 3 hours. Apixaban is the least renally metabolized at 27%. The rest is hepatic, so 73% hepatic. Edoxaban is 50-50, renal and hepatic metabolism, as well as some biliary intestinal excretion. Rivaroxaban is 50% renal. The rest is hepatic or just eliminated. And then dabigatran is the most renally dependent at 80% renal clearance. The side effects that I want you to be familiar for all DOACs is bleeding and hypersensitivity. Some special tidbits to know is that rivaroxaban can cause agranulocytosis and can also cause a Stevens-Johnson syndrome. Dabigatran commonly can cause GI effects. So you might get dyspepsia in your patient who you have on dabigatran. And a thrombocytopenia can also occur. Monitoring of the direct 10A inhibitors, you can actually do an anti-factor 10A level. That's just for the 10A inhibitors. And then for dabigatran, you can actually do a dabigatran trough level. some interaction that limits our use of drug interactions that'll limit our use of DOACs. For apixaban and rivaroxaban, there's a strong interaction between the CYP3A4 inhibitors and inducers, as well as the P-glycoprotein inhibitors and inducers. By contrast, edoxaban and dabigatran only interact with P-glycoprotein inhibitors and inducers. So some drugs that you might see listed as potentially interacting with the DOACs. Common ones are going to be antiepileptics, especially phenytoin. Other things would be kind of antifuncals, ketoconazole, itraconazole. Those are both P-glycoprotein and CYP3A4 inhibitors. Some of the P-glycoprotein inducers include rifampin, and P-glycoprotein inhibitors include dronedarone and ketoconazole. So essentially, all drugs should be screened for interaction with the DOACs, as there are many drugs that will interact with the DOACs. In terms of drug-specific reversal agents, in Canada, all we have available is idarucizumab for dabigatran reversal. For rivaroxaban, apixaban, and edoxaban, we don't have an agent available in Canada, so we actually just use PCC, prothrombin complex concentrate. So for the next part of the talk, I'm just going to talk about trials which provide evidence for the use of the DOACs in certain indications. So the first is the use of non-valvular AFib, and in these studies, the DOACs were compared to warfarin. And in the Aristotle trial, which looked at apixaban, there was decrease in hemorrhagic stroke and decrease in fatal bleeding and decrease in vascular mortality. The edoxaban study, called the Engage-TIMI trial, showed also a decrease in hemorrhagic stroke, a non-inferiority in stroke or systemic embolism prevention, and a superior cardiovascular mortality. So I'm going to write less CV death here. The Rocket AF trial was for rivaroxaban, and it was non-inferior for stroke. Major bleeding was fairly similar, but there was an increase in GI bleeding. And ICH, so intracranial hemorrhage, was lower. The RELY trial looked at dabigatran, and dabigatran compared to warfarin had increased GI bleeding, but a similar rate of major bleeding, less vascular mortality, and less ischemic stroke and hemorrhagic stroke. So next we have our VTE prophylaxis studies, and we have total hip replacement versus total knee replacement. Both comparator groups looked at enoxaparin. And the apixaban trial, which compared enox to apixaban, was the ADVANCE-3 trial, and this was in total hip replacement, and in total knee replacement we have the ADVANCE-2 trial. Both trials showed superior VTE prevention with no difference in bleeding. So same result for both studies. The edoxaban trials, I'm not going to talk about them because they're not approved for this indication, but just for reference, you can look at STARS JV here, and you can look at STARS E3 in your own time. Rivaroxaban, we have record 1 and 2 that looked at total hip replacement, and record 3 and 4, which looked at total knee replacement. Both were superior with no difference in bleeding. And then the Renovate 1 and 2 trial looked at dabigatran compared to enoxaparin and showed a non-inferior prevention of VTE. Not approved for total knee replacement, but I'll say if you'd like to look this up, they have some trials, so you can look up the Renovate trial. There's also the Renovate 2 trial, and then the Remodel and Remobilize trial. All right, so VTEs for all the VTE trials compared for treatment compared to the vitamin K antagonist, so warfarin or a low molecular weight heparin. So the VTE trial looking at apixaban was called Amplify, and it showed non-inferiority in terms of recurrent VTE and mortality, but there was decreased major bleeding. The edoxaban trial was non-inferior also for recurrence, and was superior for intracranial bleeding, so less intracranial hemorrhage, and for clinically relevant bleeding. Einstein was non-inferior for recurrent VTE as well, and mortality, with lower just general bleeding. And Einstein was for rivaroxaban. And then finally we have the Recover trial, which looked at dabigatran, again non-inferior for VTE and mortality, with similar major bleeding. Then we have secondary prevention of VTE. So this is already in patients who have completed a course of anticoagulation and the decision has been made to continue on with lifelong anticoagulation. So the Amplify Extend trial compared low-dose apixaban to placebo and showed decreased frequency of recurrence and similar major bleed. Edoxaban is again not approved for this indication, and then the Einstein Extend and Einstein Choice looked at rivaroxaban and compared both placebo, aspirin, low-dose rivaroxaban, and high-dose rivaroxaban to each other, and showed that rivaroxaban at both low and high doses prevented VTE recurrence to a greater extent than aspirin. And then for dabigatran, we have the Remedy trial, which compared to warfarin, and the Resonate trial, which compared to placebo. As you would expect, non-inferior for bleeding in Remedy, and non-inferior in prevention, and similar rates of bleeding in the warfarin trial. And for the Resonate trial, there was some increased bleeding, but superior in prevention. All right, so that concludes our talk on DOACs. So in summary, there are 4 DOACs that we use here in Canada: rivaroxaban, apixaban, edoxaban, and dabigatran. Today we went through dosing, indications, and contraindications, and we went over a bit about the pharmacology of the drugs, and we went through the trials which demonstrate the efficacy of the drugs. Thanks for listening, and let me know if you have any feedback or comments in the comment box.